Hello, my name is Renuka Iyer. I'm a medical oncologist at Roswell Park Comprehensive Cancer Center in Buffalo, New York. And I would like to thank the organizers for the opportunity to speak to you today. Thank you all for joining virtually. My talk is titled Biliary Emergency Care Real World Data. And what I'm hoping to take you through in the next 10-15 minutes is what we're finding is really happening when patients present to the emergency room that carry the diagnosis of cholangiocarcinoma. In the real world, many of us know that urgent visits are a source of stress and happen more often than we'd like, and result in interruption in the patient's planned treatment, as well as, especially depending on what the situation is, can be potentially life-threatening, especially if they have ascending cholangitis that isn't diagnosed in time. What we're hoping to do from this project and the questions we've asked is to try and gain a better understanding of where the diagnosis of cholangiocarcinoma occurs and how many patients have urgent ER visits, how many of these patients have stents and tubes, and where and who gives this care. All of these things would really allow us to better understand where we stand and how to move forward. So the way we did this was to speak through Stacy to the folks at Komodo Health. You have heard from them previously at this meeting, and what they are able to do is query a very large claims database very thoughtfully to pull some of this data. So what we decided to do was include patients with the cholangiocarcinoma diagnosis codes from a 5-year period, 2016 to the end of 2020. And what we found was if you used all of those diagnosis codes in a claim at least once, we had a lot of patients, 180,000 patients. But to be confident that these patients really carried a cholangiocarcinoma diagnosis, we decided to focus on patients that had 2 or more encounters with a CCA code. And for that, we ended up with 124,056 patients. So I will take you through the questions we asked and the findings. The first question we asked was how many unique cholangiocarcinoma patients were seen in that 5-year period, and how many unique encounters did all these patients have that could be identified through the claims. And what we found was that from these 124,000 patients, there were over 2 million, close to 3 million unique encounters. And what was interesting, you can see the distribution here of intrahepatic, gallbladder, and the number of encounters by each diagnosis. What we found was that intrahepatic cholangiocarcinoma formed 62% or were the majority of the patients. And what was interesting was that about 18,000 patients were classified as both not otherwise specified biliary cancer as well as intrahepatic cholangiocarcinoma. And for 5,000 of those patients, the diagnosis code was not otherwise specified, perhaps unknown primary, before they were properly classified or identified as intrahepatic cholangiocarcinoma, which underscores the importance of how we document and how the coding occurs in order to accurately capture these patients. The next question we had was, where is the diagnosis of cholangiocarcinoma being made? You've previously heard presentations about where the patients are getting their care, whether it's in the community or they transfer to an academic center, and that's what we were really going after. And what we found, no surprise here, that majority, 45% of patients, the cholangiocarcinoma diagnoses were made in the community. And what we found was that even though a large percentage are made in academic centers, more work is needed to better classify what is presently classified as unknown, the 22,000. And I think some of that might come from the fact that there are patients who get diagnosed in a center that's an affiliate of an academic center, and it's really hard to know where the classification occurred, or there are claims for multiple places around the same time. The next question we had was how many of the cholangiocarcinoma patients in this database had biliary stents, percutaneous tubes, or drains placed, and how many claims were present for the placement of these stents, tubes, and drains per patient per site of origin, by site of origin, meaning where the tumor originated. And as you can see, in blue are the claims for a biliary stent being placed, in red for a PTC tube, and in green for a biliary drain. And what we found was that 29% of the cholangiocarcinoma patients in this database either had a stent, a tube, or a drain. And we also found that patient counts, as we expect, likely overlap, because some patients may have had more than one procedure or more than one type of procedure. We do have patients with a stent as well as a tube. And surprisingly, this I was really not expecting, intrahepatic cholangiocarcinoma patients were just as likely to need stents, PTCs, or drains as extrahepatic, which is not intuitive. The other thing we wanted to see was how many of these encounters, or how many such codes, or how many times are these procedures occurring. And we found that the ratio of encounters per patient was in the 2.5 encounter per patient range, and it didn't matter where the tumor had actually originated. The next question we had was, how many urgent care visits occur over that follow-up time period for the total number of cholangiocarcinoma patients identified as folks with the cholangiocarcinoma diagnosis 2 or more times? And what we found was that it was a very large number of patients that had ER visits, but the percentage was 9.7%, almost 10% of total cholangiocarcinoma patients go to the emergency room. But in those patients that have stents and tubes, that number really doubles, almost doubles to 17%. They're far more likely to require urgent care, emergency care. And what we also found that patients with stents and tubes, even though they only account for about 18% of all cholangiocarcinoma, they form 39% of all the ER encounters, with a median of 2 encounters per patient. The next question we had was, so when they go to the emergency room, what is the frequent presenting diagnosis? What is the claim submitted for? And as you know, we submit these claims with many diagnoses when the patient is in the emergency room. And I don't expect people to be able to see this very carefully, but what I'm trying to point out here is that for all cholangiocarcinoma patients, if you try to make a list by frequency of what the submitted codes were, these green fonts are cancer diagnoses. So often that is expected, that they would code them as having a cancer. But in addition, the highlighted yellow lines point out things like elevated WBC count, fever unspecified, dehydration, and other things that we expect patients would have when they present with cholangitis. But cholangitis as a diagnosis ranks number 60 here in red, as the most frequent of the over 1,000 diagnosis codes that were submitted during urgent visits. This is the same list, but now for patients who have stents and tubes. And once again, you see now a lot of this yellow, a lot of symptoms of cholangitis, and now cholangitis moves up to 30th most common presenting diagnosis in an urgent visit when people have stents and tubes. So I guess the key message here was that of the 1,042 or so codes that we found, majority of the highlighted codes, yellow ones, are symptoms of cholangitis, and not all of these patients are called or diagnosed to have cholangitis right at that time. Many are actually cancer diagnosis, and it makes me wonder whether that was mistakenly thought to be the cause of the presenting problem, elevated bilirubin or pain or weakness or dehydration, or whether the cholangitis diagnosis was made in conjunction with and not exclusive of. And the fact that cholangitis ranks 30, much higher than in patients with stents than those without, also tells us that this is something that's happening quite frequently in our patients, especially all of these symptoms. The odds that this is the reason why they're going to present to the emergency room are very, very high. Our next question was, so where are these ER and urgent encounters occurring? Are they occurring where the patient actually gets their cholangiocarcinoma care, where their diagnosis was made? And I'd like to put the caveat that this is a little bit complex and not very easy, not a very easy metric to capture reliably. So I thought I'd take a moment to tell you what the methodology here that we used was. So what we looked for was all the health claims that were for the cholangiocarcinoma diagnosis, first diagnosis in that 5-year period. And all of those patients, for the requested diagnosis codes and urgent visits, we tried to see what percentage of those encounters were happening where majority of the other visits and other claims like chemotherapy, etc., surgery were occurring. And then we gave a yes or no, it happened at that same place for it at the same place where 25% of the claims, other claims were, 50% of the other claims were, 7,500. And this allowed us to kind of get a sense of where is their sort of primary center. And as you can imagine, about 60, 70% of claims coming from one place is more likely to be where they're getting the majority of their care. But it did highlight something that we all know, that majority of these patients are getting care in more than one place. So what we found was, if the ER visit occurred where they were diagnosed and receiving their care, where 100% of the claims for all their other care came, that occurred only 10% of time in the same place. So in where we could be reliably certain, where 60 to 100% of encounters were coming from that one center, patients are 10 times more likely to present somewhere else than they are to present at that particular site. So one more thing that came to mind after we knew that they are going, perhaps more likely outside their primary site was how many times was this occurring? How many ER and urgent visits did cholangiocarcinoma patients have? And also, what was the interval between these visits? And what we found was that of the 26,609 patients who had unique patients who had ER and urgent visits, 14,594 of them actually had 2 or more visits. And the median interval between the patients who had just 2 visits was 25 days. The median interval between patients who had 3 or more visits was 27 days. And the median visits for that group was 8, which I found quite high, actually. So the key message here is that of those cholangiocarcinoma patients who have urgent care visits, 55% of them are going to have more than one ER visit, and the interval of time between these visits is usually less than a month. So it's a very stressful time when this happens, and it's happening at a frequency that is, shorter than I would have expected. Our next question to the database and the analytics team was, what was the proportion of these patients with stents and tubes who had antibiotics? Because that's one other way of knowing that there was some infection, more likely cholangitis. And we were curious to know who was the provider prescribing these antibiotics or submitting the claims for cholangitis. And what we found was antibiotic prescriptions in those with stents and tubes occurred in about 42% of patients. And majority of them, almost all of those patients who got antibiotics were IV antibiotics, which also came as a little bit of a surprise. Next here you see is the list, the top 10 subspecialties of people who were submitting these claims and prescribing these antibiotics. And as you can see, an oncology subspecialty ranks very low in that list, only accounting for about 5% of all those claims and submissions, telling us that majority of the providers caring for patients when they present with urgent symptoms, especially for what we're trying to get after and understand, are not oncology subspecialists. And these are folks that we need to reach and perhaps spread this information or alert about this complication. So with that, I'll make some closing remarks. This real world data really highlights some important things. One message for urgent care centers and ERs is that they need to be aware of cholangiocarcinoma as a cause for biliary obstruction, and also in the patients that have stents, what the appropriate stent management is. And for patients that are listening and that we come in contact with, we should be talking to them about these problems and educating them so that they are empowered to help with this awareness. And one of the ways they can take charge and be advocates for their own care is by carrying a biliary emergency card that can be found on the cholangiocarcinoma.org website. And the last piece of takeaway message here for the cholangiocarcinoma community is that we need to continue the efforts that we have started already to raise awareness of the diagnosis, including the importance of coding properly so we can identify these patients and do this kind of work, and also use of the consensus guidelines that you just heard about for optimal management of our patients with cholangiocarcinoma. And with that, I'd like to end with some thank yous. Dr. Juan Wale has been my collaborator and partner in analyzing this data and putting together this slide set. Stacy Lindsay from the Cholangiocarcinoma Foundation, who passionately supports every question we ask and put us in contact with the Komodo Health Analytics team, who did a marvelous job, especially Paul Zakas, Paul Moss, and Melissa Agnello. And all of you in the cholangiocarcinoma community for all you do, especially this crew here. And with that, I'll end with my contact information and look forward to hearing from you with any questions or clarifications that you might want. Thank you.